Bismillahirrahmanirrahim. On to the third session of our CVS unit. Last time we were discussing about the anatomy of the CVS and we talked about the anterior-posterior structures. The most anterior one was right ventricle, then we had the left atrium, that was the most posterior structure. The left lateral border was being formed by the left ventricle and the right lateral border was formed by the right atrium. So remember the ventricle and atrium because they are, stuff like that. Then we saw the problems of your murderer who has to stab you through all these layers before reaching your heart. And then now let's move to the CT scans. Now this is the endorsement of the previously learned concept. Sorry. So we have previously learned that the right ventricle is the most anterior structure. This is the sternum over here. So this is the most anterior structure. That is the right ventricle, and the most posterior structure is the left atrium. It is not very well evident in this picture because esophagus on the CT scan is most likely to be collapsed. As you can see, if you could zoom it in, so this is esophagus. It is collapsed in this picture, but in this picture it is partially open. So I guess you can see some area of air in the esophagus. So esophagus normally in the CT scan is collapsed. So the area that is right anterior to the esophagus will be left atrium. This is right side and this left side. Okay, so the right lateral border is formed by the right atrium, while the left lateral border is formed by the left ventricle. Same picture is over here with different angle. Right ventricle anterior most, left atrium posterior most, right atrium on the right border, left ventricle on the left border, and posterior to all of these things we have aorta as well. Then esophagus. Okay, then here we have the section of the CT section at a different different level. So here you can see initially the pulmonary trunk is okay. So this is the right side, right, and this is the left side. So the aorta moves anteriorly. This is ascending aorta. Then it start moving posteriorly all the way to behind the esophagus. Okay. Pulmonary trunk. Pulmonary trunk normally resides anterior to the aorta. So this is pulmonary trunk. Then we have the aorta that originates posterior to the pulmonary trunk, then comes over it and then goes behind it as descending aorta. Superior vena cava is on the right side. Main stem bronchi are these things, and esophagus and the pulmonary trunk. So this, you can see this division, by the way. This thing is called as the pulmonary trunk. So this is pulmonary trunk, and this round structure anterior, not anterior, you may say to the right side of the pulmonary trunk is the ascending aorta. This one is descending and superior vena cava. Here you can see again, this is sternum. Right ventricle is just adherent to the sternum. Left atrium is adherent to the esophagus. Right atrium is forming the right border of the heart, and left ventricle is forming the left border of the heart. Spinal cord is over here, and then descending aorta. In this picture, you can see the menobrium is over here. So basically, it's an upper level of CT section. This is part of the right atrium on the right border. Superior vena cava is also present. If you can see it. Okay. Then we have right pulmonary veins. Pulmonary veins like this. This is the bifurcation you can see. So pulmonary veins are over here. Then spinal cord, inside is spinal canal. In this thing, esophagus is over here. This is esophagus. This thing. Let me zoom it. Yeah, this is esophagus over here. This thing, that is esophagus. Then we have descending aorta like this, and the one of the left pulmonary veins. So basically we have two pulmonary veins like this in this. So in this CT section only one is evident. Then we have ascending aorta like this and the pulmonary arteries. And let's move forward. So here you can see this is CT scan, but they have not labeled that, so we will not study that. Now let's go to the next one. So here you can see the right pulmonary artery on the right side and on the left side. Then we have superior vena cava pulmonary arteries. Then we have superior vena cava. So they don't ask you about very complicated CT scan. CT scan on the step exam are simple. Like they're not very intricate. Like this is a very intricate one. Only a radiologist can understand what thing is like, because normally they don't tell you about the section of the spinal cord as well. Not spinal cord, the vertebral column section, like T4, T5 they have written here. They don't tell you about that. So it is very hard to describe this section. But let's see that this body of sternum, then ascending aorta is over here. Pulmonary trunk is going like this, and that's ascending aorta and spinal cord. Okay. There are different pictures. Then again on the right side we have superior vena cava. So you must remember the gross things, like superior vena cava is supposed to be present on the right side, and ascending aorta is present on the relatively left to the left side of the superior vena cava, then descending aorta, and then descending aorta is always on the left side, and ascending aorta basically comes from the right to left, so that is why it is found on the right side. Then T4 vertebra, ribs and scapula and blah blah blah, and there is some demarcation. So if this is a picture, I saw this picture somewhere on the step exam, on the not step exam, on the Uworld exam. So here you can see the aorta. This is right ventricle over here, then left ventricle, then pulmonary artery, and then we have the embolus, which is obstructing the pulmonary artery. Okay, then we have, okay, this is very high yield. They will give you a cardiac shadow, and then they ask you to infer what thing is where. So you must remember that. Firstly, this is the right side, and this is the left side. First, get this straight. Now you must remember the structure which are present on the right border, then the structure which is present on the left border, and before anything you must remember that the most anterior thing, this anterior surface is formed by the right ventricle. Clear? So the anterior surface is formed by the right ventricle. Okay, now on the right border you are supposed to find superior vena cava, most superior structure. Then this curvature is formed, the right border is formed by the right atrium, and then we have the inferior vena cava, that is, even if not visible, the most inferior most structure. Okay, actually these are not basically superior vena cava, because superior vena cava is something like a structure like a pipe. So this is just a line. So these are not superior vena cava, this is the shadow or the margin of the superior vena cava as evident on the chest x-ray. Okay, then inferior vena cava shadow is over here. Okay, so we are done on the right side, that is superior vena cava, right atrium, and the inferior vena cava. On the left side, starting from above downwards, the most superior structure is the aortic knob, like the arch of aorta. It looks something like this. This is the arch of aorta, and we have a knob of that which is visible. Then pulmonary artery. Then we have left atrium, which is forming the left border of the heart, this curvature. Then the left ventricle. Left ventricle. Pardon me. No. Left ventricle is forming the border of the heart, and left atrium is forming the most posterior structure. The shadow of that is also evident. And then we have the right ventricle, anterior most structure, and this thing is called as the apex. Apex. So remember these things. So on the left side we will find aortic knob, pulmonary artery, left atrium, left ventricle, and the right ventricle. These things are very important to remember because they often ask you about these things on the step exam. Then we have surface anatomy of the heart. 2 multiplied by 3 is equal to 6 plus apex. What does that mean? So it starts from the second intercostal space. I'm not sure what does that mean. Okay, so the interventricular septum sulcus is present in the mid-clavicular line, maybe in the, okay, so this is the right side and this is the left side. Okay, this is the second intercostal space, and this is the sixth intercostal space. On the right side it is tilted a bit, so on the left side it starts in the second intercostal space to the fifth intercostal space, while on the right side it is from the third to sixth intercostal space. Okay, I guess this is what it means. I'm not sure about this picture, so if anyone has a better explanation, kindly explain this in the comment section, because I'm seeing this picture for the very first time. So this is the second intercostal. So basically the extent of heart in the left side is second to fifth intercostal space, and on the right side it is third to sixth intercostal space. Okay, then it is just half inches towards the right of the sternum. Otherwise it is most of the heart is situated on the left side. Okay, then the coronary sulcus is present on this side, like on the right side. The heart is situated something like this, and like this. Heart is a structure like this, right? So the coronary sulcus is present on the, because right atrium is present over here, and the coronary sulcus is posterior, is situated posterior to the right atrium. So the position of the coronary sulcus in the living heart is parallel to the right sternal border. Okay, so this is coronary sulcus, that is also called as the AV sulcus. Then the interventricular septum, that is situated midway, or you may say in the mid-clavicular line on the left side. Okay, that is the position of the interventricular septum, and it is half inches towards the right and 5 inches, at about 5 inches towards the left side. Okay, and the heart most of the time it is, suppose it is a nipple is in the mid-clavicular line, and if we draw a line, so most of the time heart is on the mid-clavicular line, or maybe just behind the mid-clavicular line. So that is the normal position of the apex of the heart. So that is a good picture. Remember this one, or if I'm wrong about anything about in the picture, so kindly explain that to me. Then let's move forward. Left ventricle is forming the lateral border as well. This is left ventricle, and left ventricle is abutting the lung, and the right atrium is forming the right border of the heart. The right ventricle is the anterior surface, while the left atrium is forming the most posterior structure of the heart. Now let's talk about the valves. The aortic valve, second right intercostal space. I guess that's a beautiful picture. There must be another picture as well. Okay, so the second right intercostal space at the right sternal border. This is right side, this is left side. So this is A area, you may also call it A1 area. So the second right intercostal space at the right sternal border. Okay, this thing called it pulmonic valve. The pulmonic valve, the second intercostal space at the sternal border, at the left sternal border. So pulmonic valve is the second left intercostal space at the left atrial border. So basically the aortic and the pulmonic valve are parallel to each other. You may not say, you can't say parallel, but in line with each other. The aortic area or the aortic valve is on the right side, while the pulmonic area or the pulmonic valve is on the left side in the same intercostal space, that is second intercostal space. The tricuspid valve is over here, fourth left intercostal space at the left lower sternal border. So the fourth left intercostal space at the left lower sternal border is the tricuspid valve, fourth or maybe fifth, but mostly fourth. So this is the area of the tricuspid valve, the fourth left. Now only auscultatory area on the right side is that of the aortic area. All the other areas are on the left side. These are auscultatory areas. Remember, I will differentiate the areas of the right and left heart after the table. So tricuspid, fourth left intercostal space at the lower left sternal border, and the mitral valve, fifth left intercostal space. This fifth left intercostal space medial to the mid clavicular line. That is very important. If this is mid clavicular line, suppose this is mid clavicular line, so it is medial to that. Medial is towards the center, so it is towards the center, that is medial to the mid clavicular line. Okay, now remember the areas. These are four areas which are very high yield areas, very important. Now the aortic, these two areas, the pulmonic area and the tricuspid area, these are the sites, these are basically areas of right heart, while the mitral area and the aortic area, these are the left heart areas. So the murmur of right heart can be heard on these two sides, the pulmonic and the tricuspid area, and the murmurs originating in the left heart will be heard on aortic or the mitral area. Clear? Now there are some maneuvers. For example, if we are supposed or even during the general physical, not general physical, I mean during the cardiac examination on the patient, when we have to listen to these murmurs, if any, so we ask the patient to inspire deeply and then hold the breath, because on inspiration the blood movement towards the right heart increases, and resultantly if there is any murmur present in the right heart, that will be exaggerated. If we have to listen to these left heart areas like the aortic or the mitral area, so we ask the patient to expire completely and then hold the breath, because in expiration because during expiration the blood flow towards the left heart is increasing, and resultantly if there is any murmur in the left side of the heart, that will be exaggerated. Moving forward to the next page, anatomy of the conduction system. Now we have conduction system is consistent of the sinoatrial node, the pacemaker, from where the impulses for the contraction of the heart are being generated. Then we have the atrioventricular node, which is over here, AV node. Then atrioventricular bundle, which is present after the AV node. Then AV bundle splits into right and left bundle branches, and then the Purkinje fibers originate from that, and they are supplying the muscle to the ventricles, and over here the apex, left ventricle, and left atrium. So remember, the conduction system is originating in the right atrium. The SA node is in the right atrium, AV node is in the right atrium, then the conduction pathway is in the interventricular septum, and then the right and left bundle branches will move towards the ventricular branches. The anatomy of the AV node location. The AV node is located on the endocardial surface of the right atrium, near the insertion of septal leaflet of the tricuspid valve and the orifice of the coronary sinus. Now this is very important, the location, because they test you on this concept. They may ask you the location directly, or they may ask you something else about it. So maybe they label an area near the tricuspid orifice and then tricuspid leaflet, and then they may ask that what is that structure that is present over here. So it is near the insertion of septal leaflet of the tricuspid valve and the orifice of coronary sinus. If they give you a structure like this, and anything in this area, this close vicinity of the tricuspid valve, that is going to be the AV node, right? Now let's talk about SA node. Before that, radio frequency ablation. How do we do that? Performed in the patient with the arrhythmia who do not respond to the pharmacologic therapy. Locations to the AV node is occasionally. Another area frequently involved in the atrial fibrillation pathogenesis is the opening of the pulmonary veins in the left atrium. The area is often targeted for the radio frequency ablation, but is not where the AV node is located. So what do we do in the atrial fibrillation pathogenesis? Pardon me, AV node occasionally. So why do we do the ablation? Ablation means that we are going to damage or destroy the particular area in the conduction pathway. Why do we do that? Suppose we have supraventricular tachycardia, or that supraventricular tachycardia, that is atrial contraction rate is atrial heart rate is higher than the ventricular heart rate because of some problem. There is arrhythmia going on. That supraventricular tachycardia worsened to form atrial flutter, or even worsened to form atrial fibrillation, right? So we don't want all the impulses which are going crazy or frenzy on the atria to reach the ventricles, because even if the person is having atrial fibrillation or supraventricular tachycardia, that is not so dangerous as is the ventricular tachycardia or ventricular fibrillation, because the cardiac output is dependent mainly on the ventricular contraction. right? And 80% of the blood from the atria is not dependent. 80% blood flow from the atria to the ventricle is passive. So the contraction of the atria is accounting only for the 20% of the blood flow. So if a person is having fibrillation, atrial fibrillation, and the atria are not pumping, so the decrease in cardiac output will be less than 20%. So somewhat near the 20%. So it is not more than that. So if we are having the atrial fibrillation, a person is having that, we give them medications. If the antiarrhythmic medications are unable to control this effect, so what do? We do the radio frequency ablation of the AV nodes, so that the frenzy impulses which are generated in the atria are not conducted into the ventricles, right? So when we do that, so there after a period of suppression, maybe the Purkinje fibers, or maybe the bundle of His, they generate an ectopic focus, not ectopic focus. They come out of suppression and they become pacemaker themselves. So yeah, maybe the Purkinje system is becoming the pacemaker, or maybe the Purkinje fibers, they start generating the impulses for the ventricles. The rate is lower, but they do that. Then we can also another area frequently involved is the pathogenesis, the opening of the pulmonary veins. So pulmonary veins open over here, if you could see this. So this is the opening of the pulmonary veins. These are the pulmonary veins and opening over here. So this can be the site of formation of ectopic focus, or the site of origin of the supraventricular tachycardia or arrhythmia in the atrium that may lead to the atrial fibrillation. The most common, you may say that, the most common site of beginning of the atrial fibrillation is this area, the opening of the pulmonary veins on the left atrium. Is the opening of the pulmonary veins in the left atrium. This area is often target of the radio frequency ablation, but is not where the AV node is located. This is not the site of AV node. AV node can also be ablated by the radio frequency ablation method. Anatomy of the SA node. It is located in the upper anterior right atrium at the opening of superior vena cava. That is very important. You must remember that this node is present, the SA node is present at the opening of superior vena cava, and the AV node is present at the opening of tricuspid valve. So you must differentiate them from each other. Biventricular pacemaker of the heart. What does that mean? A device that requires 2 or 3 leads. If 3 leads are used, the first 2 are placed in the right atrium and right ventricle, and the third lead is used to pace the left ventricle. Okay, it is biventricular pacemaker of the heart, the artificial device which we place. So if we can use either 2 leads or 3 leads. If we have 3 leads, so 2 of them are placed on the right side, that is right atrium and right ventricle, and 1 is placed for the left ventricle. The right atrial and ventricular leads, easy to place, as they only need to traverse the left subclavian vein and superior vena cava to reach these chambers. For the right-sided leads, atrial and ventricle, we only need to puncture the subclavian vein in the upper limb, and then we push the leads inside the vein, and ultimately they reach the superior vena cava, and from superior vena cava into the right heart and also the left heart, right atrium and the right ventricle. They reach the right atrium and the right ventricle, but it is difficult to put the leads in the right ventricle. It is difficult to put the leads in the left ventricle. Okay, so the left ventricular lead, more difficult to position. The preferred transvenous approach involves passing the left ventricular pacing lead from the right atrium into the coronary sinus, which resides in the atrioventricular groove on the posterior aspect of the heart, is then advanced into one of the lateral venous tributaries in order to optimize the left ventricular pacing. So this is the preferred route. In the preferred route, so here you can see that we reach the right atrium and right ventricle. Cool. So right atrium and right ventricle are covered. Now we have to push the lead to the left ventricle. How do we do that? This requires high precision. So how do we do that? We push the lead into the coronary sinus, then from the coronary sinus into the venous tributaries, which are supplying the left ventricle. So this is the position. This is difficult positioning of the lead. So you must remember that. Posterior aspect of the heart is then advanced into one of the lateral venous tributaries in order to optimize the left ventricular pacing. The pulse generators over here. Then we have the left ventricular coronary sinus leads, right atrial lead, and right ventricular lead. Uworld point is coronary sinus. Venous drainage of the heart opposite of the right atrium and normally not seen by echo. The coronary sinus, venous drainage of the heart is dependent on the coronary sinus. It opens in the right atrium and normally not seen by echocardiography. So coronary sinus dilation is due to the increase in the right-sided pressure because of pulmonary hypertension. Okay, so whenever there is right-sided pressure, so that right-sided increase in the pressure, venous drainage of the heart is dependent on the coronary sinus. The coronary sinus is draining the blood from the heart, the venous blood from the heart into the right atrium, right? So it opens into the right atrium and normally it is not seen on the echogram. echocardiogram. But this vein, now just forget everything about the placement of the leads. This vein is draining the blood from the heart into the right atrium. In the case of coronary sinus dilation is due to the increase in the right-sided pressure because of the pulmonary hypertension. So if there is pulmonary hypertension and there is an increase in the pressure on the right side, in the right ventricle and then in the right atrium, so this vein, the coronary sinus will be dilated. Okay, what is blunt aortic injury, traumatic aortic rupture? Mechanism: sudden deceleration that results in extreme stretching and torsional forces affecting the heart and aorta. Injury occurs most often in the aortic isthmus, proximal descending just distal to the origin of left subclavian artery. The proximal descending aorta, just distal to the left subclavian artery, is called as the aortic isthmus. And if there is blunt aortic injury, we're talking about the aortic injury, that is a site of damage which is tethered by the ligamentum arteriosum and is relatively fixed and immobile compared to the adjacent descending aorta. So whenever there is blunt injury, the rest of the descending aorta may move somewhere, but because it is tethered or attached to the ligamentum arteriosum that was previously called as ductus arteriosus, which fibrosed to form the ligamentum arteriosum. Now because of that fibrosed structure, this part of the descending aorta, that is the isthmus, is very fixed, and this is the point of injury of the aorta in the blunt trauma. The majority, 80% of the patient die from the aortic rupture before reaching the hospital, because that is the first artery. You may say that first artery, aorta is the biggest artery to come out of the heart, and that contains high pressure system. The 120/80, the highest pressure of the blood is found in the aorta, and if that is ruptured, so there is so much internal bleeding that the person does not survive and that the journey to the hospital. Those who survive the initial injury have non-specific findings such as chest pain, back pain, and shortness of breath, and it is hard to identify the problem. So widened mediastinum may also be seen on chest X-ray. Okay. Then we have this thing that is called as the ascending aorta. So this is aortic root, and the ascending aorta, anterior segment arches. So anterior segment of the arch. Then this is aortic isthmus over here, which is just let me zoom it in. So this is ligamentum arteriosum, which is attached to the aortic isthmus. This is the narrowest portion, as evident in the picture. So then descending aorta and ligamentum arteriosum and stuff like that. Okay, so here you can see in this part of the diagram over here. So this is, this is osseous pinch. Yeah, that is basically osseous pinch is the bony contracture that is felt on the surface of the chest. This sternum, and if the blunt is over here, if it is punch, so it is exerting the force in that direction. It will exert the force all the way to the aorta, and this isthmus portion that will get compressed between the vertebral column on the back and the ligamentum arteriosum on the anterior surface. That is the site of rupture in most of the cases. So there will be stretching or maybe shearing. Okay, so in both the situations, that is the most vulnerable area. Coronary arteries anatomy. So now let's come to it. So the coronary arteries are originating from the bulb of aorta or the base of the aorta, both the right and left coronary arteries. The right coronary artery is originating over here, and the left one is over here. The right coronary artery is going to give rise to acute marginal artery. Okay, acute marginal artery on the right border of the heart. Now we are on the anterior surface, right? Yes, and then it also gives the SA nodal branch, and anterior lead also give the SA nodal branch or the atrial branches. Forget about that. The right coronary artery on the anterior surface is going to give the anterior marginal artery, acute marginal artery. This is the pia vena cava and pia vena cava, aorta, and left atrium, pulmonary veins, left coronary artery. Now let's move to the left coronary artery. The left coronary artery on the anterior surface is going to give the left anterior descending artery, or the LAD. It is most commonly stenosed or obstructed branch in the case of myocardial infarction. So this area, the left anterior descending artery, the area of supply is also mentioned, and the anterior surface, this much anterior surface of the ventricle is supplied by the left anterior descending artery, while the whole of the anterior surface of the right atrium and ventricle is being supplied by the right coronary artery, but we'll see about that later on. Then the right coronary artery turns backward. This left. So the left coronary artery turns backward, and the right coronary artery also turns backward, because they also have to supply the back of the heart. So then if we turn the heart upside down, so this was right side, this was left side. Now if we turned it upside down, so this has become right side now, and this is left side. So on the left side, starting from the left side, the artery, when it turned back, it became left circumflex artery, LCX, left circumflex artery, and this artery is called as Obtuse marginal artery, that is also a marginal artery. Over here, the obtuse marginal artery is a terminal branch of the left circumflex artery, and left circumflex artery is a branch of the left coronary artery. Or you may also say that the obtuse marginal artery is a direct branch of the right coronary artery, and the left circumflex artery is a separate branch. Okay, so these two arteries are coming from the left coronary artery, and the left coronary artery is also supplying the left atrium. Then the right coronary artery, which turned backwards. Here you can see that the right coronary artery is moving backwards, and it is forming the posterior descending artery. Now here is the concept of dominance, that the artery which will give the posterior descending artery is the dominant artery. Most of the people have right dominant circulation, which means that the posterior descending artery is originating from the right coronary artery. But in some 30% of the people, the left circumflex coronary artery may give rise to the posterior descending artery, but that is a rare, not so rare, but in the 30% of the people this can be the case. So now let's talk about LAD. LAD is this artery, anterior surface. Yeah, this is the LAD. Okay, so LAD, anterior surface of the left ventricle. Okay, now let's remove all of the things. Yeah, this is the left ventricle, and now we are talking about this artery. So the LAD is going to supply the anterior surface of the left ventricle, anterior 2/3 of the interventricular septum, anterolateral papillary muscle, and most commonly occluded artery is the LAD artery. Remember, anterior 2/3 of the interventricular septum. Suppose if I am drawing a lateral view of the interventricular septum, this is the interventricular septum. From the, this is anterior surface and this is the posterior side. So the anterior 2/3 of the interventricular septum is being supplied by the left anterior descending artery. The posterior 1/3 is supplying by the posterior descending artery. But let's keep our focus on the LAD. So the anterior 2/3 is being supplied by the left anterior descending artery. Okay, now moving forward to the posterior descending artery. The posterior descending artery is on the posterior surface and coming from the right coronary artery in most of the people. So we are going to talk about this artery now. The posterior descending artery, AV node, dependent on dominance. AV nodal artery arises from the posterior descending artery if right dominant, or left circumflex artery if left dominant. Okay, now this is again a major conceptualization factor. This is, I have to rebuild my concept. I'm sorry. The dominance, according to this thing, because my concept was dominance is dependent on the posterior descending artery, but now they are saying that the dominance is dependent on the AV nodal artery. That is, AV nodal artery is a branch of what? Posterior descending artery, right? The AV nodal artery is coming from the posterior descending artery, and if so, basically it is the same thing, just annotated in a different way. Yeah, that's just, it is a different way of presenting the same thing that I previously have told you, that the AV nodal artery is a branch of posterior descending artery. If the AV nodal artery is coming from the right coronary artery, so that is right dominant, because in that case the posterior descending artery is also coming from the right coronary artery. And if the AV nodal artery is coming from the left coronary artery, this means that PDA is also derived from the left coronary artery. So basically this is just the same thing. Remember, whatever you feel like. Dependent on the dominance, AV nodal artery arises from the posterior descending artery if right dominant, and from the left circumflex artery if left dominant. It is going to supply posterior 1/3 of the interventricular septum, posterior 2/3 of the wall of the ventricles, and posterior medial papillary muscle. It was supplying the anterolateral papillary muscle, and this is supplying the posterior medial papillary muscle. Right acute marginal artery supplies the right ventricle, and diaphragmatic surface of the heart composed mainly of the right ventricle. So diaphragmatic surface of the heart, it is the anterior. So diaphragm is basically over here. So this is being formed by the right ventricle, because right ventricle is the anterior-inferior border. So you may say that, yeah, anterior and the lower border of the heart is being formed by the right ventricle. So that is being supplied by the right coronary artery. The posterior descending artery is basically supplying these areas. Posterior 2/3 of the ventricles and posterior both ventricles. Posterior 2/3 of both the ventricles and the papillary muscle. Posterior medial papillary muscle. Right acute marginal artery supplies the right ventricle. And diaphragmatic surface of the heart composed mainly of the right ventricle, from the right ventricle. Okay, so talking about the interventricular septum, we previously have discussed that anterior 2/3 is supplying by the left anterior descending artery. So the anterior 2/3. So the anterior 2/3 is supplied by the LAD. The posterior 2/3 is supplied by PAD, PDA, posterior descending artery. Now let's move forward to the right coronary artery supplies the SA node. Blood supply independent of the dominance. The AV nodal blood supply is dependent on dominance. It will depend, because PDA is the determining factor of the dominance. If PDA is coming from the left, so AV nodal artery is from the left coronary artery. If PDA is from the right, so the AV nodal artery is coming from the right coronary artery. But the right coronary artery SA nodal branch is independent of the dominance. It will always come from the right coronary artery. In fact, may cause nodal dysfunction, bradycardia, or heart block. Dominance. The right dominant circulation, which is in 85% of the people, posterior descending artery arises from the right coronary artery. The left dominant circulation is 8% of the people. It arises from the left circumflex artery, and co-dominant circulation is present in 7% of the people. That is arises from both left circumflex artery and right coronary artery. So this is the Uworld pictures. We have seen all of these things. This is the posterior view. So posteriorly, this is the right side and this is the left side. So here you can see the right coronary artery giving rise to the posterior interventricular septal branches. No, the posterior interventricular branch, posterior descending artery of the coming out of the right coronary artery. Then we have the right marginal branch over here. Then there is the nodal branch, then circumflex branch of the left coronary artery, atrioventricular nodal branch, and the posterior left ventricular branch, blah blah blah. This is the anterior surface, no, this is not anterior surface. So these are both posterior surfaces. This one was the right dominant circulation. This is the left dominant circulation, in which the posterior interventricular branch, posterior descending artery of the left coronary artery is coming from the circumflex branch of the right coronary artery. Left circumflex branch of the right coronary artery is giving rise to the posterior descending artery. Coronary blood flow peaks in early diastole. It is very important because the coronary blood supply is basically blood supply to the ventricles. Major chunk of that is to the ventricles. Now when the heart is contracting in the systole, the coronary circulation is compressed. The coronary circulation is blocked during the systole. As soon as the heart starts going into diastole or heart relaxes, it is that part when the heart gets the blood. So heart gets the blood after giving the blood to the whole body. When the whole body is distributed, the heart relaxes and then it gets the blood. So basically it is just like the parent who just firstly they will feed the children, and when the children are well fed, then they will relax and then they will be fed. So this is the function that we see in the heart. Then in the coronary blood flow peaks in early diastole. Okay. So the papillary muscle of the heart, the papillary muscle of the mitral valve, posterior papillary muscle supplied by the posterior descending artery, and anterior papillary muscle has dual blood supply, that is lead and left circumflex artery, but both are branches of left coronary artery. So posterior papillary muscle is supplied by the PDA or the right coronary artery. Anterior papillary muscle has dual blood supply from the lead and left circumflex artery, less likely to rupture after the MI. So most likely to be ruptured is this one because it has single blood supply, that is posterior descending artery. And if this one has double, because it has double blood supply, so that is less likely to be ruptured after the myocardial infarction. Here you can see the anterior lateral papillary muscle supplied by the lead, and these are the posterior medial papillary muscle which is supplying by the posterior descending artery, lead and left circumflex artery. Okay, so this is the aorta, pulmonary trunk, aortic valve, anterior leaflet of the mitral valve, left ventricle, and then we have the chorda tendineae, posterior valve of the mitral leaflet, posterior leaflet of the mitral valve. I'm sorry. This is lead stenosis, as you can see. On the anterior surface, if there is stenosis, that is the lead stenosis. Left main artery, which is giving rise to left anterior descending artery, now that is stenosis, so that is the lead stenosis. In this it is angiogram. Yeah, and then we have the left circumflex artery over here, that is normal. It is the right coronary artery. Okay, all right. Moving forward, this is the left anterior descending artery stenosis, that is also picturized in this picture as well. So here you can see this is the left stenosis over here. Okay, then we have this Uworld point. So Uworld point, the optimal size for obtaining the vascular access in the lower extremity during the cardiac catheterization is common femoral artery below the inguinal ligament. The optimal site for obtaining the vascular access in the lower extremity during the cardiac catheterization is the common femoral artery below the inguinal ligament. Cannulation above the inguinal ligament can significantly increase the risk of retroperitoneal hemorrhage. Pericardium. Now what is pericardium? It consists of 3 layers. From outer to inner, firstly we'll have fibrous pericardium, then parietal layer of serous, the parietal layer of serous pericardium, and the visceral layer of serous pericardium. So first thing is the outermost structure, that is the fibrous layer, that is fibrous pericardium as depicted over here. So this is fibrous pericardium, the green one. The fibrous pericardium is encasing the heart completely. It is tethered with the diaphragm as well at the cardiophrenic ligament, I guess it is. So there is some ligament between the fibrous pericardium and the diaphragm, that is the ligament, central ligament of the diaphragm, I guess. Then we have okay, so this is also encasing the base of the greater arteries, for example aorta. So great vessel, base of great vessel is also covered by the fibrous pericardium. Got it? Then we have the serous pericardium, the serous lining. Basically serous lining is you can say that the lining that is formed of living cells, or the serous of the serosa, the lining of the serosa. So it has 2 layers. One is the parietal pericardium and the other one is the visceral pericardium. So it has 2 layers. So unlike the pleura, which has 2 layers, pericardium has 3 layers. The outermost layer is fibrous pericardium, then comes the parietal, and then the visceral pericardium. The pericardial cavity lies between the pericardial and the visceral layer. So pericardial cavity lies between the parietal and the visceral layers. Accumulation of the fluid in the pericardial cavity compresses the heart, resulting in the cardiac tamponade. Pericardium innervated by the phrenic nerve. Pericardium is innervated by the phrenic nerve. Pericarditis can cause referred pain to the neck, arms, and one or both the shoulders. Open left side. Okay. Here you can see the okay, I'm sorry. It is the pericardial. Okay. So I guess the visceral pericardium is also called as epicardium. This is the heart inside, and then over here you can see the pericardial cavity and the diaphragm. So moving forward, now we have to talk about the CVS physiology. So CVS physiology, the important terms are end diastolic volume and end systolic volume. So here you can see when the heart is relaxing, the end diastolic volume of a ventricle is this much, or if you may say this is like this much. Yeah, something like that. So basically end diastolic volume is over here, and end systolic volume is lesser than the end diastolic volume, so it is just this structure. So end diastolic volume is filling completed and contraction is beginning. Contraction is so basically when there is maximal at the end of the diastole, just before contraction starts. When there is maximal filling of the ventricle, that is called as end diastolic volume. And what is end systolic volume? Emptying is completed and relaxation is beginning. So just before the relaxation begins after the systole and the heart is contracted to its maximum, that volume that is still present in the heart is called as end systolic volume. What is stroke volume? Stroke volume is equal to end diastolic volume, this one, minus the end systolic volume. So this is the maximum amount of volume that could be pushed into the circulation, and this is the volume that is left after the maximum cardiac pumping. So the difference between the end diastolic volume and the end systolic volume is the stroke volume. Okay, ejection fraction is the stroke volume divided by the end diastolic volume. So whatever was the stroke volume, if we divide that by the end diastolic volume, okay, so this is the amount of blood that was pumped, and this was the potential amount that could be pumped. So the ratio between both of them will give us the ejection fraction. Cardiac output is equal to stroke volume, this one, multiplied by heart rate, how many times the heart is beating. Stroke volume means the total amount of blood that is being pumped in one beat. When the heart beats one time, the total amount of blood that is pumped into circulation at that in one beat of the heart, multiplied by the total number of the time the heart beats in 1 minute. So that is the heart rate. So stroke volume multiplied by heart rate will give us the cardiac output per minute. So if you are having hard time remembering it, so remembering it that it is cardiac output per minute. So we have to calculate the cardiac output per minute, and then you will get to know that it is something that we have to multiply with a heart rate. And what should we multiply with the heart rate? It is the amount of the blood that is ejecting from the heart, not ejecting per se. It is the amount of blood that is leaving the heart in one beat. So total amount of the blood. So that is the stroke volume. So stroke volume multiplied by heart rate will give us the cardiac output. And the ejection fraction is not an absolute or discrete value. It is the fraction. It is the ratio between the stroke volume and end diastolic volume. What is venous return? The blood return to the left ventricle should be equal to the cardiac output. So the venous return is the total amount of the blood that is returned to the left ventricle. So that is very interesting because the blood normally returns to the right atrium, but whatever, okay, suppose let's draw a heart over here. So this is the heart, this is the right side, this is the left side. So superior vena cava is over here and inferior vena cava is over here. So and these are the atria, like atrium over the right atrium, the right atrium, left atrium, and the right ventricle and left ventricle. Okay, so this is my heart, and normally the venous return comes to the right atrium, and but ultimately from the right atrium it has go to right ventricle and then to the lungs, and from left atrium to the left ventricle. So ultimately whatever blood is coming back is coming ultimately to the left ventricle. So that is why they are defining the venous return in reference to the blood that is returned to the left ventricle and should be equal to the cardiac output. Okay, so whatever blood is returning back must be equal to the whatever blood was pumped outside, right? So total peripheral resistance to the blood flow from the peripheral structures. Vasoconstriction increases the total peripheral resistance and vasodilation decreases the total peripheral resistance, and the maximum amount of resistance in the circulatory tree is conferred by the arterioles. Arterioles are the site of maximum resistance. So if the arterioles are constricted, the total peripheral resistance has maximum increase. If they are dilated, so there is decrease in the total peripheral resistance. So remember that. Systolic blood pressure largely determined by the stroke volume, and diastolic blood pressure, it is largely determined by the total peripheral resistance. Pulse pressure is equal to systolic blood pressure minus the diastolic blood pressure and proportional to the stroke volume. Mean arterial pressure is equal to 2/3 of the diastolic blood pressure plus 1/3 systolic blood pressure. So mean arterial pressure is equal to 2/3 diastolic blood pressure plus 1/3 systolic blood pressure. Cardiac output, mean arterial pressure is what? So you may say the mean arterial pressure is equal to 2 into diastolic blood pressure plus systolic blood pressure over 3. I don't know from where the equation is coming, but this is the equation for the mean arterial pressure. Like 2 diastolic blood pressure plus systolic blood pressure over 3, or 2/3 of diastolic blood pressure plus 1/3 systolic blood pressure. Then cardiac output. More cardiac output is equal to more work, which means more oxygen demand. Cardiac output is equal to heart rate multiplied by the stroke volume, or you may also say that cardiac output per minute, just for the sake of remembering it. Determinants of the cardiac output are stroke volume, the contractility, preload, afterload, and heart rate. Cardiac output is equal to rate of oxygen consumption divided by the arteriovenous oxygen content difference. It is very important because although this equation is also difficult to remember, but this is the most difficult thing to remember in the whole CVS unit, because you never put some attention on the oxygen consumption in reference to the cardiac output, and they usually ask you about that. They will give you the rate of oxygen consumption or maybe the arteriovenous oxygen content difference, and then they will ask you that which other value is supposed to be calculated. They won't ask you to calculate this. They may give you both the values and ask you to calculate cardiac output, or vice versa. But the point is that in one of the Uworld questions, they were asking that if this arteriovenous oxygen difference is given, or the cardiac output, or not even cardiac output, they told me that the heart rate and stroke volume is given. So what else is needed to calculate the cardiac output? So we needed the rate of oxygen consumption. So there was some, the formula is very important. Cardiac output is equal to rate of oxygen consumption divided by the arteriovenous oxygen content, because if there is increased amount of cardiac output is directly proportional to the oxygen demand or oxygen consumption. Yeah. So the rate of oxygen consumption can be determined with the oxygen meter by measuring the rate of disappearance of oxygen in the exhaled air. Now let's talk about stroke volume. The stroke volume is affected by the contractility, afterload, and preload. Afterload is basically the total peripheral resistance, the load that is after the heart, okay, which is after the ventricles, that is in the arterial tree, and the preload is the load that is coming into the heart. So venous return is preload and arterial resistance is the afterload, in easy words, if we are talking about the left ventricle alone. Increased stroke volume with contractility, for example anxiety and exercise. Decreased preload, for example early pregnancy. If there is a decreased preload, so the stroke volume will be increased. Decreased preload, I guess it is wrong, it is increased preload. It must be decreased afterload but increased preload. Stroke volume, because in early pregnancy, stroke volume, I guess it is a misprinting, so it must be increase in the preload. Whenever there is increase in the preload or increase in the venous return, for example in the early pregnancy, we have increased amount of the blood that is, so basically there are a lot of physiological changes in the pregnancy. One of them is increased preload. Let me check that, but I guess it is increased preload. Preload in pregnancy. So preload, what does preload? It increases, right? Uterine contraction during the labor result in the increased cardiac output. After delivery, the cardiac preload increase. After delivery, the cardiac preload increase as a result of decompressible law. It's after delivery. What is hemodilution? Is a preload contraction. Okay, what happens with increased preload? Preload increase in pregnancy. So the blood volume expands rapidly until the 34th week, after which there is only the modest rise. Cardiac output increases by 30 to 50%. First, the preload increases owing to the rise in the blood volume, because blood volume is increasing, so there must be an increase. So kindly correct it in your PDFs. Increase in the preload is present in the case of increased stroke volume. A failing heart has decreased stroke volume, systolic and diastolic dysfunction. Okay. Now even the decrease in afterload will cause an increase in stroke volume. Okay. So contractility, how hard the heart muscles squeeze, that is contractility. So ejection fraction is the index of contractility. Major regulator is sympathetic nervous system, also increases the heart rate. So the cardiac muscle, we have seen this picture before. The beta 1 receptor linked to the GS protein, they increase the CAMP, increase the calcium, and increase the contractility. So calcium will enter the cardiac muscles. They will act on the sarcoplasmic reticulum, and there will be calcium mediated calcium release, and that will bind with the contractile filament, the myosin and the actin, blah blah blah. They will cause a contraction. And also, so basically, I'm sorry, let's start it from here. Whenever the beta 1 receptor is bound by the norepinephrine over here, so GS will be stimulated. The beta 1 receptor will coupled to the G stimulator, so they will activate the G stimulator, that will activate the adenylate cyclase. Adenylate cyclase will convert the ATP into cyclic AMP, and cyclic AMP will activate the protein kinase A, and that protein kinase A will cause the opening of the calcium channels. Calcium will enter the cardiac myocytes. Calcium will act on the ryanodine receptor on the surface on the sarcoplasmic reticulum, will cause further release of the calcium, that is called as calcium mediated calcium release, and that causes contraction. Now it's clear. Now let's talk about to increase the contractility in stroke volume. what do we have to do? And then to decrease the contractility and stroke volume. To increase the contractility and stroke volume and contractility can be increased by catecholamine stimulation by the beta 1 receptors. What happens? Calcium channels are phosphorylated, calcium entry, calcium induced calcium release, and increased calcium storage in the sarcoplasmic reticulum. Because if more calcium is entering, more will be stored in the sarcoplasmic reticulum, so more calcium storage in the sarcoplasmic reticulum occurs in this way. Phospholabam phosphorylation activates the calcium ATPase, and increase, because the phospholabam is going to, we studied that phospholabam normally down regulates the sarcoplasmic. Sarca is basically the calcium ATPase which pumps the calcium. So sarca is basically the endoplasmic reticulum channel that pumps the calcium into the sarcoplasmic reticulum for storage, and phospholabam is an inhibitor of sarca. If we give the beta 1 stimulation will inhibit the phospholabam. So phospholamban will cause the will be inhibited, and sarca will come out of inhibition. Resultantly, more and more calcium will come into the sarcoplasmic reticulum. There will be increased calcium storage in the sarcoplasmic reticulum. So this was something that we saw in the physiology of the musculoskeletal system. Kindly check those videos for more details. Then increased intracellular calcium. Okay, so with the catecholamine stimulation, we have increased in intracellular calcium, decrease in extracellular sodium, decrease activity of the sodium calcium exchanger. Digitalis block the sodium potassium pump, increase intracellular sodium, and decrease sodium calcium exchanger. So when we give the digitalis, okay, so listen, increase in intracellular calcium because of any reason will also increase the stroke volume. Decreased extracellular sodium, decreased activity of sodium calcium exchanger. Okay, sodium calcium exchanger is located on the surface of cells. This is sodium calcium exchanger, suppose, and just close to that we have sodium potassium exchanger as well. So sodium calcium exchanger is going to cause the calcium efflux in response to the entry of the sodium. Like this is sodium, and this is calcium. So for calcium efflux, we have to bring the sodium inside, right? Or you may say the sodium entry favors the calcium efflux. If the extracellular sodium is decreased, so the calcium will not be able to leave the cell, because calcium cannot leave the cell, because sodium cannot be brought inside because extracellular sodium level is low. So this will cause an increase in the stroke volume. Secondly, what is the function of digitalis? Now digitalis blocks the sodium potassium pump, increase intracellular sodium, decrease sodium calcium exchanger activity, and increase intracellular calcium. So this is the sodium calcium exchanger, and sodium potassium ATPase pumps the sodium outside to bring the potassium inside. So these two things work together in such a way that the sodium potassium ATPase will set the gradient for the sodium to be excessively present outside. Now this gradient will bring the sodium inside for the exchange of calcium. Now this is a this is a good example of secondary active transport, that is ATP is consumed only by sodium potassium ATPase. The ATP is used to put the sodium against the concentration gradient outside in the extracellular environment, and potassium inside, both against the concentration gradient. Now when a gradient of sodium is established outside, it is easy for the sodium to move inside. Now the sodium, when it moves inside from the sodium calcium exchanger, the calcium automatically, as reverse active transport, is pushed outside. So the ATP is not used in this process, but ATP is consumed by this channel. So both of these channels are linked together. Now what is the function of digitalis? Digitalis will block this one. If the digitalis is blocking the sodium potassium ATPase, the gradient of sodium is not established. Resultantly, sodium will not come down the concentration gradient, and the calcium will not be expelled out. And if the calcium is not expelled out, resultantly, what do we find is that the calcium concentration inside the cell is increasing, and resultantly the contractility will also increase. Now let's see the mechanism to decrease the contractility and stroke volume. Beta 1 blockade decrease the cyclic AMP, heart failure with a systolic dysfunction. Okay, the beta 1 blockade, so basically that is the reverse of all the discussion which we did on the left side. Heart failure with a systolic dysfunction. In the systolic dysfunction, the major problem is that the ventricles can contract. The contractility defect is called as systolic dysfunction. Acidosis, remember this one, hypoxia and hypercapnia, and non-dihydropyridine calcium channel blockers. So all these things are going to cause a decrease in the stroke volume. Then moving forward, what is the lusitropy? It is very important because it is when we start doing these tropies, the chronotropy and the inotropy and the dromotropy, blah blah, a lot of that. So this one is this one is taken for granted in most of the cases because people don't remember this one. I also used to ignore this one, so let's not ignore it this time. Lusitropy, myocardial relaxation mediated by the sarca. Circa is a channel that is going to, so this is the concept I was previously talking. So it is basically the relaxation. We were focusing on the contractility so much that we forgot to mention the relaxation one. So myocardial relaxation mediated by the circa. Circa is regulated by a protein called as phospholamban, PLB. Phospholamban is an inhibitor to the circa. Sympathetic stimulation phosphorylates the phospholamban, decreases the phospholamban, increases the circa, because circa will come out of inhibition. Faster relaxation that leads to faster contraction. That is a very beautiful concept, that whenever there is beta 1 stimulation, the heart will relax fast so that it can contract fast, right? And the faster relaxation means the diastolic duration will be decreased, and faster contraction means the number of systolic cycles are increased. So the total contraction, the total duration of the heart in the diastole is increasing, and the the total duration of the heart in the systole is increasing, and the diastolic duration is decreasing because there is faster relaxation. This is that concept. So let's see preload and afterload. Preload is the volume of the blood in the ventricles at the end of diastole and diastolic pressure, increased in the hypervolemia, regurgitation of the cardiac vessels, and heart failure. That is increase in hypervolemia, regurgitation of cardiac valves, and heart failure. What is afterload? The resistance left ventricles must overcome to circulate the blood. Okay, so there is the resistance that the left ventricle must overcome to cause the circulation of blood. Increase in the hypertension and vasoconstriction, increased afterload, and increased cardiac output. Okay, so we'll talk about the concept of preload and afterload in the next session. Until then, Allah Hafiz and Fi Amanillah. Take care.